Hi. While they're pulling up the slides, I'm just going to introduce myself. So I'm new to Penn. I've been here for about 3.5 months now. So I moved from the University of Michigan, having grown up on the East Coast. I thought I became a Midwesterner, but I think actually I belong on the East Coast. So I'm very happy to be back. I've joined really a tremendous team here at Penn. I'm really very privileged to have been recruited here and to be able to continue some of the work that I did at Michigan and be able to expand to, to other areas of research and clinical care. So this is a topic I've thought a lot about over the years. We started our clinic at Michigan 12 years ago, and it was very apparent early on that, not surprisingly, exercise was really important to a lot of people. There was a lot of fear, a lot of uncertainty about what they should be doing, shouldn't be doing, what the risks are, and a lot of questions that we did not have answers for. So, I tried very hard along with many other colleagues at Michigan and other institutions to come together to try and provide some more answers and some more information to inform decision-making surrounding exercise and sports participation in individuals with hypertrophic and dilated cardiomyopathy. So most of my talk's going to be about HCM and DCM. My understanding was there weren't many participants here with arrhythmogenic cardiomyopathy, but certainly I'm happy to address that either during the question period or during the breakout sessions. Oh, I should probably figure out how to advance the slides. Where's the, is it here? Green arrow, thank you. Okay. So for practical reasons, we've kind of grouped exercise recommendations into recreational and competitive exercise, but I think we all recognize that there's a lot of overlap between those two. Recreational is sort of defined as leisure time activity, whereas competitive sports is done sort of for the purpose of pursuit of excellence and competition against others. In general, we sort of think of recreational maybe as being kind of a lighter intensity, sort of slower pace. And people doing competitive exercise is doing a harder intensity or a faster pace. It's not always true, and I think there's clearly exceptions. We all have seen the back of the pack runners, right, who, they put a number on and they're competing in a 5K, but they're not really competing against other people. They're out there really just to enjoy themselves for the purpose of fitness and accomplishment. And we've certainly seen a lot of cyclists I have around here. I think they're pretty crazy, actually, riding around Philadelphia. I have not ventured out on my bike, but they're hitting the pavement really hard, and technically they're not competing against anybody except maybe on Strava, but they're pretty intense, and they're certainly getting their heart rates up and well into the realm of other competitive athletes. So I think it's really helpful to think about the sort of the spectrum of exercise rather than these kind of sharp divisions, but we end up practically having to do that for the purpose of guideline writing. Talking about guidelines, first I just kind of want to give you an idea of what guidelines are. I think many of you are familiar with it. There are guidelines for everything, particularly in cardiology. There's guidelines for managing heart attacks, for managing heart failure, for managing valve problems. And we have guidelines for managing hypertrophic cardiomyopathy and dilated cardiomyopathy, which falls mostly under the heart failure guidelines. And guidelines are written by experts in the field. Usually a team of people are put together that's, in the U.S. is mostly U.S. Experts, but there are also usually some international representatives, team of maybe about 20 people or so. And that team collects all the available information from published studies on the topic. And randomized controlled clinical trials are the most influential, but as you've heard from Dr. Lin and others this morning, that we don't have a lot of randomized control trials in HCM and genetic DCM. And so many times we are restricted to commenting on things based on expert opinion and maybe some observational studies, but we don't have as many randomized control trials as we would like to, and hopefully that will change. So for competitive sports participation, I'll tackle this first. There are several guideline documents in the U.S. and Europe that have addressed this, and the last update was in 2015. That was a U.S. guideline update. And it really hasn't changed substantially over the past now almost 15 years since it was first published, and that the recommendations are that all individuals with cardiomyopathy should be excluded from participating in most competitive sports. And what I'm going to show you is that there is more information that we've been gathering, since that time in the last 4 or 5 years, including population data. And I also share with you that the guidelines for HCM are in the process of revision, and they will due to be published in just over a year. It is a 2-year process. process, and is, invokes a lot of discussion and it is a lengthy review process, so that we can provide the guidelines that really represent a consensus opinion from experts in the field. And I can tell you that this is one topic that we are tackling and really thinking hard about whether the restrictions that have been imposed in previous guideline documents are really justified based on available data. There are also guidelines for recreational exercise. These are quite outdated. As you'll see, 2011 was the last update to this guideline. And in general, they've kind of ranked sports and different exercises according to their level of intensity and whether they have components of anaerobic or burst exertion, which are considered perhaps at highest risk of triggering dangerous heart arrhythmias. And so at one time, I used to give this chart out. It's this complicated 2-page table with all these numbers and all these activities. And I stopped doing it because I really didn't find it very useful for patients, because I think, that everybody brings a different level of activity to a particular sport or exercise. So tennis players can be all over the map, right? And so can swimmers. And I can tell you that master swimmers would be very insulted by the fact that people thought they were doing low to moderate intensity activity. So now I really provide more of a sort of a spectrum based on not so much the sport or activity itself, but kind of what level of intensity somebody's bringing to that. And all these guidelines on recreational exercise up to this point had been based on expert opinion. There really were no data in this realm whatsoever. And of course, our biggest concern, and the reason why this invokes so much discussion and controversy, is the concern for the potential risk of triggering a cardiac arrhythmia that could cause a sudden cardiac arrest or death. And this is really the public perception, particularly for HCM. Hank Gathers, now 30 years later, is still sort of the poster child of HCM. And when I ask patients in clinic who are newly diagnosed what they know about HCM, they said it's the condition that causes basketball players to drop dead. And it is an enormous misconception, because the reality is that these are incredibly rare events, and that the vast majority of events that do occur, first of all, they're rare to begin with, and the vast majority are not occurring in athletes, but these are the ones that get a lot of public media attention. But it certainly raises a level of concern and something that we need to address, because people are very worried about what they should be doing, including competitive sports. So there are a number of recent studies I'll share with you that suggest that the risk of exercise and sports participation may be lower than originally thought. The estimated annual incidence, for example, for sudden cardiac arrest in patients with HCM is 0.2 to 0.3%. That's probably a lot lower than most people think. These are incredibly rare events. The other thing that is commonly stated is that HCM is the most common cause or the leading cause of sudden cardiac death in young people and in athletes. This is actually not true. This has been disproven through multiple population studies, both in athletes and in young people in many parts of the world. And HCM uniformly accounts for between 3 and 10% of all sudden cardiac arrests or death. And DCM is similar and somewhere in that ballpark as well. And so actually by far the most common cause of sudden cardiac death in young people is we don't know. And so most of the time, it's even on close microscopic examination of the heart, it's uncertain, even with genetic testing on postmortem samples. So we still have a lot to learn, but I think that this helps to inform kind of the recommendations about sports participation, just knowing that the incidence of these events is very rare, and that cardiomyopathy is a rare cause among those. And the other thing to note is that most events occur during routine daily activities at rest or while sleeping, and I think this is not the perception of most people. They think that and some will say, well, if I stop, exercising, then I'll be safe and I won't be at risk of dying. And so that's not true. And conversely, it's not necessarily true that if you continue to play sports that you are putting yourself at risk. And so these are really the questions that we need to tackle. What is the risk of sudden cardiac arrest for individuals with a known diagnosis of HCM or DCM who are engaged in recreational or competitive exercise? And is that risk higher than in individuals who are less active? And I'll tell you, we don't know the answers to these questions, but it's something that we're actively seeking. So this is one study that really started to get people thinking about the safety of sports for patients with cardiomyopathy. Now, this is a study that was done in athletes who had defibrillators for a number of different reasons, but 65 of them had HCM and 31 had dilated cardiomyopathy out of the 372 athletes. There were no deaths, no resuscitated arrests or shock-related injuries in any of these athletes. And there were more shocks generally during physical activity, but there was no difference between those that were in competition or practice than that were doing their usual sort of recreational activity. The majority of athletes who experienced shocks chose to continue to play, and so that was their decision. It's, supporting patient autonomy to say, I know I was shocked and it saved my life, and I'm going to go back to my sport, and I'm comfortable with that. And the rates of shocks were similar to those reported for less active populations of patients with ICDs, but there wasn't a so-called control group here, so everybody was an athlete. We didn't have a way. Well, I wasn't involved in the study. They didn't have a way of determining whether the rates of shocks were higher in athletes because there wasn't a non-athlete group for comparison. So the next iteration of this study is the LIVE study, and this is one I have been involved in with Rachel Lampert at Yale and Mike Ackerman at Mayo Clinic. There are many sites, including Penn, who have enrolled patients in the study. Some of you may be in this room are participating in the LIVE study, which is lifestyle and exercise in HCM, and we have a companion study in long QT syndrome, which is an arrhythmia, a genetic arrhythmia syndrome. And so the purpose of this study is to try and understand how first of all, what exercise people are doing, so to capture kind of a baseline level of exercise. We're not prescribing exercise, we're not endorsing anything, we're simply observing what people are already doing, and then looking to see how they do in over 2 to 3 years or longer. And we hope to extend the study for many more years beyond the original designated 3 years. But what we understand is how does exercise affect their quality of life? How does it affect how they do in terms of whether they have arrhythmias, whether they get shocks from their device, and so on. And so we've completed enrollment. We have about 1.5 years left to finish the 3-year time point, and hopefully we'll have results reported out soon after that. So although my clinic is a bit enriched for athletes because of my interest, certainly the vast majority of patients I see are not athletes. And some of them don't exercise or don't necessarily like to exercise. And so I spend a lot of time convincing people that exercise is a good thing. We know there are tremendous health benefits, both physical and mental health benefits from exercise. And what happened to, I thought I was on a different slide. So let me just go back for a second. I thought I was on a different slide. Okay, forget what I just said. I'll come back to that in a second. So this is a couple studies now that looked at what happens to athletes if they stop playing versus continuing to play sports. And of course, we think that we're protecting people if we withdraw kids or adults from their sports. But it turns out in these 2 studies now with small numbers, albeit, that looks like there's no difference in event rates over many years in those that stopped playing sports versus those that continued. And this was really encouraging. In fact, this study actually showed that those that stopped playing sports had a higher rate of arrhythmias. This is a mixed population, many different genetic conditions in here, not just cardiomyopathy. Small numbers, but I think food for thought. Okay, this was the slide I thought I was on. So the non-athlete with HCM or DCM, so what should we do with them? So I've been a very strong proponent of encouraging moderate intensity exercise, and usually at the AHA recommended minimum of 150 minutes a week. The updated guidelines now say really should go up to 300 minutes a week. So that equates to 30 to 60 minutes 5 days a week of walking or something else equivalent to that. But almost 50% of patients with HCM are not meeting these guidelines. Patients with HCM are less active than the general population. Many of them have reduced exercise following their diagnosis, and this has had a negative emotional impact for many. This was a survey-based study that we did a number of years ago. And patients with HCM have a higher body mass index. There's a very high prevalence of obesity in the patients with HCM, and it's up to 70% of all patients with HCM in a large registry study that we're about to report. Has either overweight or obese, so it's a real problem, and clearly exercise restrictions, may have an impact on that. So it's something that we need to address. You heard about this study from Dr. Lin this morning. It was very kind of her to highlight the Reset HCM study, which was a randomized study of exercise training in HCM patients that we performed at Michigan in collaboration with Stanford. And this was all in adult patients. We randomized them to moderate intensity exercise versus their usual activity and individualized their exercise prescriptions. So nobody was necessarily doing the same thing as somebody else, but it was really tailored to them. And as Dr. Lin mentioned, we showed that exercise training improved exercise capacity without adverse events. There was no difference in the rate of arrhythmias, and we had no serious events in either group. So this was very encouraging, and I think has provided some reassurance for providers to encourage patients to do at least a moderate intensity recreational exercise as part of their heart health, overall heart health. Exercise in DCM, exercise training studies have been conducted in dilated cardiomyopathy patients in large numbers, and clearly there is a benefit, and this is part of the current guidelines for heart failure and the basis for recommendations for patients with heart failure to participate in cardiac rehabilitation. So there's been no signal for harm in these studies, and exercise has been shown to improve functional capacity, exercise duration, quality of life, and mortality. So in summary, I think, we still have a lot of information to gain. We have a lot to learn, but I think about exercise on a continuum and taking people who are inactive and bringing them to at least a light to moderate intensity activity, again, sort of focusing on the AHA recommended 150 minutes to 300 minutes a week, which has been shown to have a benefit for overall heart health. And it may have a benefit specifically for cardiomyopathy. We don't know that yet. But we certainly want people to be exercising and active and not restricted or feel like they can't do anything. There is a huge gray zone in the vigorous to competitive or high intensity. In this case, I made it purple. But this is an area where we really need more information, and there is kind of a spectrum of practice in terms of what providers recommend for patients. And how risk-averse people are, and there's a lot of things that go into these decisions. I think more and more providers are starting to recognize the importance of patient autonomy and shared decision-making, as we do in all of medicine, in this area as well. But again, we need more information to really inform these decisions. So I think it's also important to not sort of send someone on their way after even a lengthy discussion about if they've decided that they're going to go ahead and continue in their sport. Whether it's a child or an adult, and I'm addressing the adult audience here, but I think things that I tell people to be as sort of precautionary notes is that if they're going to be participating in an organized sport, that they should know whether there's an AED on site, and ideally make sure there's an AED on site, more likely to be used in somebody else than for them, but it's a really important life-saving tool, and to know that it works, it has batteries, and that there's an emergency action plan, and it's not behind a locked door somewhere. For the adult population, for sort of the busy, working family, parents who like to go out and play basketball on the weekends, but they don't really have time during the week because they're working and dealing with everything else. And I tell people to not try and avoid this sort of weekend warrior thing, because I think if your heart's not well conditioned for a particular sport, you may be putting yourself at higher risk. So I really encourage people to build a strong aerobic base before they go out and do more high intense sports. To heed warning signs and not be stupid, right? Use common sense. If you don't feel good, if you're dizzy or lightheaded, don't keep playing. Sit down and, and kind of reassess the situation, get help if you feel like, you're really not feeling well. Make sure you're staying well hydrated. Dr. Riza highlighted that, particularly for HCM patients. This is very important during exercise. And particularly for those who have a defibrillator, to wear a heart rate monitor. And usually I recommend a chest strap because the wrist ones don't work very well, and they're just not very accurate. And you really want to make sure you're keeping your heart rate at least 20 beats below your ICD cutoff so that you don't get inappropriately shocked. And this is more of a problem for young people who can get their heart rate up to 200 when exercising. So that's all I have for now, and I'd be happy to take questions during the question and answer session. Oh, is there not one? Okay, well then never mind. Okay, I didn't look at the agenda carefully, but during the breakout session, thank you.